Dr. Josh Sabari. Josh is assistant professor in the Department of Medicine.
Here, this tumor is on the outer edge of the lung, and it's at the...
And this is one of the ways we're trying to push the envelope with some of these non-invasive.
He is also the site director for radiation oncology in the Cancer Center.
With pulse electrical field, and then subsequently with radiotherapy with a complete response. And this turned out
study where we were looking at these patients that could get surgery, but they're at a high risk for a problem.
Here, you can see how you can very carefully dissect the lymph nodes, remove
a lot of suspicion. There's some data from the Cancer Research UK group on stages where cure, especially with surgery, is very challenging. That we've shown that
not do that. But at the same time is a smaller operation and allows you to remove
a rare mutation. I want to focus on KRAS, which is a very common mutation.
Lung cancer. And immunotherapy is an integral part of the standard of care for lung cancer patients, often a tumor. This is a national study at 12 centers nationwide that was co-led by my therapy called Viral Immunostimulatory Gene Delivery in a few minutes.
Cancer space. We also heard about small cell lung cancer. So small cell lung cancer.
We could otherwise give a pill or giving something by vein. One is that
tarlatamab on the left, and on the right-hand side, you see after 12 weeks of therapy. In the clinic right now, under investigation in clinical trials. There are novel move into the frontline setting in the near future with ongoing clinical trials.
Interstitial lung disease and things of that nature, but age alone, I'm not discriminatory.
Therapy or any other immunotherapy for the specific cancer. And we studied this together with...
We do chemotherapy and radiation, and now we do immunotherapy afterwards. And for stage...
And you see less deaths happening with the screening group. Usually patients present late and older.
The surface of cancer cells that will allow us to predict who will respond well to
58% reduced lung cancer mortality at 10 years, which is phenomenal for screening. The diagnosis in patients who have family relatives.
Potentially use something called proton therapy to make the radiation less toxic.
And you would enforce that the spine is going to be free of tumor.
Compound in studies, they see 9 times more damage.
Is important not only for you, your family member, but also for people who may come in the future.
Some stage 3 disease that's resectable is for surgical resection. For unresectable stage 3, AI into our treatment repertoire. Not tolerate surgery. However, we are looking, and Dr. Pass and I participated in would have issues if you cut out a large portion of the lung. One of the machines...
Years later on average, is there anything that can be done to combat this resistance?
Initially was used as a curative option for frail patients who could not get surgery. So
myself, but as I mentioned, at multiple academic centers around the country in which...
Try to better understand this disease and using some transcription factor quite complex. This is a disease that is seen exclusively in people who have hip coordination with a really deep and nice response to tarlatamab.
To introduce to you Dr. Benjamin Cooper. Ben is Associate Professor of Radiation.
Lung cancer, a recalcitrant disease where therapies really have not improved.
Oncology. He's a professor of cardiothoracic surgery and vice chair for research in the department, caring for patients with lung cancer. One
area, this is for an assistant, but many times you don't need an assistant and the patient only...
Just put it in one direction. And where that can be helpful is if they do one of those wedge resections.
Resectable cancers. Immunotherapy helps your immune system fight the...
And the plasma. We'll also talk about PDL1, which is a marker on these 2 genes called P53 and RB1. And to make the story, percent of people with HER2 mutation receiving this medicine had profound response and everything right by you.
And one thing that we could do if it only progresses in
guidance by radiology or directly through a bronchoscope used
with pills. So for HER2 mutations, for very long, we have not had any Sokolov. So really an integrated network. And these are folks predominantly treating...
Be able to do, have a preoperative response. Therapies that could be given preoperatively to somebody like this who would be...
In general, maybe you could talk about that. Where are we with those?
Yeah, I mean, I think there's been a lot...
In the United States, they looked at lobes versus... Absolutely. for the spine, live longer and have a better survival and actually have more.
These novel intratumoral therapies in lung cancer and the ways that they can integrate with other therapies going on.
Overall, it's good news because this is the mortality from lung cancer.
What's new in that area in terms of breakthroughs? And certainly there's been much excitement. So Josh?
That's really great news. And that's because we're finding lung cancer.
Never smokers. And are they different cancers?
To therapy. And not only is it a short response, but people have durable.
We're also studying, as I mentioned, a variety of immunotherapies that we can inject directly into the.
To show you here is probably the most practice-changing data we've seen in small cell.
You see this instrument is now dissecting to get a place, even a smaller resection as far as you taking the amount of lung.
For malignancy is something that probably is going to be available in the next few years.
Okay.
So by really having the computer analyze, millions of
Tarlatamab, formerly known as AMG 757, and it's a very novel. Dr. Marissa Ribstein, as well as more recently in Brooklyn at NYU Brooklyn with Dr. Alyssa.
And in a comparison to a matched cohort of patients also with refractory stage 4 lung
supports wedge in carefully chosen early cases. The analogy is
cancer team is pattern recognition. And I think that when we have a question, we often bring
wedge surgery require high precision and finding tiny vessels and airways.
Shua started in practice. He mentioned we really only had chemotherapy, but now we
into the regional lymph nodes. And again, these approaches, as you've heard before,
the future is very bright. And I think enrolling in a trial in the second line
would give the patient radiation, but stop all the radiation before it gets to this pink structure, the heart. And with all of the new physics advances and computer advances and everything else that we've had.
Cancer?
I think you can. I think that part of what we all do in our lung cancer, for those in high-risk categories, but even for those who may be in categories that we can't necessarily
be cured of their lung cancer. And what she did is a study of 1,000 women.
Device, literally a needle that's put directly into the tumor, either under CT scan.
Ahead of it, right? So by using liquid biopsy or circulating tumor DNA, we can
to target the radiation, the safest dose, the most efficacious dose, when to give a higher dose. It does this that you may have seen advertisements for is something called CyberKnife. That's basically, or get to the other lung, whereas a regular X-ray radiation plan does give some radiation
by vein and deliver them directly through novel endoscopic technologies into tumors.
You've heard already that lung cancer is quite a heterogeneous disease. There are multiple different types.
But you're operating on a tumor that has been treated. It's usually these days chemotherapy. You can do a segment or a wedge in certain patients that are the candidates for it. Has one site that you're going into the chest. Let's look at just an example of what's
spot that's just sort of hanging around. We'll try to use radiation to kill those
segments. This is the left lung. The right lung has similar segments. So with a
pass, Harvey is the Stephen E. Banner Professor of Cardiothoracic Surgery from 2005 to 2021.
Either with or without bypass, and patients have done very, very well.
Day by day, month by month. So again, there is a lot of hope in the diagnosis of lung cancer. Led by Dr. Velmaswamy, specifically looking at a novel agent, BBO.
So happy to be here with all of you.
In Long Island as well, NYU Long Island with Dr. Jeff Schneider and Dr.
Changed. And there's a lot of factors that have made it change. First of all,
cancer is a different biology. We've been talking about non-small cell lung cancer. So
in combination with chemotherapy and with surgery and with radiation therapy. So what else is
options for you? But I want you to be rest assured that the medication is working and your doctors are doing. We've been the sort of lead sites for accrual in some of the FDA-approved therapies, modalities to diagnose lung cancer early. And something that I want you to understand tonight is that
in surgery, interventional pulmonary, and that's how you're going to get the best outcomes for your patient.
Actually, a patient of Dr. Shashua who was referred to me in probably early January.
And it was advised early on that the body develops resistance to you.
We will be leading a global phase 3 clinical trial using this intratumoral.
Some of the conventional therapies stop working. So show you some of the preclinical
of the chest, the mediastinum. if they cannot go for if they cannot go.
Lab, we are able to even model resistance mechanisms in animal models and think about. So DLL3 is one of these factors that is expressed in small cell cancer that started in the lung and learned how to travel elsewhere in the body. Each line here on this graph is an individual patient, and the downgoing
Clear on the CT scanner, checked always during surgery. And the key idea
More damage from the x-rays. So you could see here, normally x-rays interact
screening younger patients. Should we be screening patients who never smoked? A lot more
surgery if they are at high risk for surgery.
in segmentectomy, if the tumor is here, it would be great just to remove.
Which we did not speak on, but maybe we can spend a few minutes.
size of the individual patient's tumor cells, you see a dramatic regression.
And the robot does not act on its own. It's a 3D magnified view. It's a very areas of the lymph nodes and do a more complete resection. And at least at our place,
The
enough
5-year survival data is improving dramatically. So when Dr. Shusha
here is to get the right patient with the right tumor, with have a same.
Thank you, Harvey. Dan, why are lung cancer rates increasing?
Advanced refractory non-small cell lung cancer. So we presented this data.
we have novel immunotherapies, we have novel targeted therapies, and we also have better
Offer unique synergies with surgery, radiation, and immunotherapy to allow another arm.
More effective and try to cure more patients is with something called a radiosensitizer. So some
Patients. So I think that's a very key thing to success. Okay, so now
30% of people are alive now with lung cancer at 5 years. And this brings up a
from the radiation. So you can basically get a higher cure rate at a lower dose.
also had dramatic response in a right upper lobe mass. On the left-hand side, you see the
What about other uses of radiation and other uses of
Certainly, it's a proven cure. It's still best for many cancers.
In our interventional pulmonary operating room. Here is a patient on the left-hand.
in radiation, perhaps. So Ben, the floor is yours.
Twig. So what are some of these newer options? Well, a segment.
Again, go ahead.
Thank you, Dr. Shashua. Thanks. Post-tarlatamab with ongoing response in the right upper lobe.
These are two representative studies that shows that if you compare
NYU. It's basically we're looking at using AI to direct our dose planning and dose recommendations.
This large tumor in the right upper part of the lung, and 6 months.
tumors are small and on the outer edge of the lung with CT screening that we find, and surgery cures cancer with smaller operations and better treatments and protect.
So I saw one of the questions actually already was how can we
Surgery isn't weaker surgery, it's tailored surgery. Well, how do we do surgery?
We modified cold virus into a tumor mass adjacent to the trachea in a patient with in the blood specimens pre compared to post. And we plan a follow-up study in early stage.
Thank you so much, Dr. Shashua. I appreciate the introduction, and thank you all for taking the time out of your evening when there's lots of Dr. Sabari is going to talk about, I'm sure, and Dr. Pass is going to talk about, and using drugs and really focus on the lung tumor. You could see that red dose there is really just going to the lung BRT. So what we've really been trying to do as a group, and I collaborate with Dr.
in the brain. It's important for us to monitor the brain closely, and here you can see
The second one you'll hear about next with Dr. Sabari, that's systemic therapy or therapy that goes
Top that. Dr. Sturman is a professor of pulmonary.
everywhere in the body. That can be chemotherapy, immunotherapy, and he'll probably talk to you about some of the
is more selective, more precise than a lot of the other HER2 targeted.
Patient's own unique profile. And there's obviously a potential to combine local therapy.
Show you that the time for a patient to recur is actually less.
The charge at NYU for many trials in the frontline setting, people newly
In
diagnosed.
which you just remove that piece of lung that has the tumor. Both are true cancer.
So with that, I want to thank everyone for their attention and looking forward to the questions, true targeted therapies. We started studying this medicine, zongertinib.
Years. So Dan, please take it away.
because you're less likely to get a response, when to give a lower dose because you can give a lower dose and it's decreased the recurrence rate after surgery. And We'll discuss that in a second as well.
In a nodule, which is visualized on the lung cancer screening scan, or even remarkably,
Since they're progressing with radiation or other modalities like that.
That's a great point. We do always try novel therapies that can overcome these resistance. So there are multiple agents.
Ground glass, which means you can see through it, so it's a less aggressive cancer. The lymph nodes.
what is the future of this therapy? Can we impact both local and systemic disease while decreasing toxicity?
Decrease smoking, certainly some influence of screening. But
this is before the injection. This is after the injection, and we can put it into the tumor and the lymph nodes. Implantable radiation mesh. So you could see this mesh here has
whatever the therapeutic is that you're injecting directly within the tumor or in the lymph node. You can potentially
more work ongoing in this field. I want to pivot to patients who have stage 4.
Bill Moore from Thoracic Radiology, in which percutaneous pulse electrical field was delivered algorithm in our thousands of patients who have been through lung cancer screening and trying to correlate.
Then I think that we would get in contact with our friends.
They keep going. And that's helpful if you're trying to take a chest x-ray, if you're standing in front of a tumor, and the majority of the lung is spared if you look at this x-ray and there's no radiation going to the
R2, which occurs in about 2 to 4% of patients with non-small cell lung cancers. If we did a low-dose CT screening, could that increase the detection
for the future? And you're still aiming for a complete cure. So smaller surgery.
Improvement in survival compared to historical controls in patients who had already failed frontline.
L3, you see that it's highly visible or highly expressed in this type of therapy. I'm going to focus more on patients who have more advanced disease. Here are my disclosures.
And here are 2 examples of that from Japan and from the United States and from
problem after surgery, whether that's needing oxygen or whether it's some other issue.
That console then, through the surgeon's manipulations, is controlling for less aggressive. And it comes in families. So the
PD-L1 inhibitors, those are the standard immunotherapies. And it's really hard for the trial with a low-dose CT were identified to have a lung cancer. Most of
All right. Great. Thank you all. Just want to point out.
And this will hopefully make the radiation kill all of these tumor cells much better.
May develop in the future, even with the absence of an abnormality. So we're looking at the simple.
Has an arm that blocks DLL3, which is seen on the small cell lung.
Can help give the tumor more dose, but the surrounding lung and esophagus
conjugated to an antibody, as well as many targeted therapies. So the main question
about here at NYU. This is just one of the patients that we treated where basically
to treat up front, get all these antigens that are present in the tumor.
And so, Harvey, welcome, and look forward to your talk.
Thank you, Abe.
You can put this mesh right on top, and the gold is very dense.
Sure that the kids don't have it, or that it's in families, and you can try to monitor.
Chemotherapy, immunotherapy, or even a targeted drug therapy you'll hear about with Dr. Sabari, that Dr. Pass discussed, where they cut out a piece of the lung and put the staple line there.
You compare low-dose CT screening with control group, and you have
today, and I'm happy to address some more questions in the Q&A.
Now, I'm going to introduce you to
as well as systemically. This can be applied directly into tumors using a variety of different endoscopic.
Very top of the lower portion of the lung. This is the division between.
The question is for you. Can you see on a CAT scan if the nodule looks like it may or may not be, or those with other health problems?
I would say yes.
About why are we seeing lung cancer in never smokers? My colleague, Dr.
Delivery of cell therapies. But in addition, you could deliver energy directly to the tumors, patients prior to surgery, to see if we can improve on outcomes of surgical resection. I mentioned
artery and the lung, so that then you can do further resection.
New treatment modalities, and so we are here to talk to you about those things. And
Incision. This is the newest, smallest robot with a single port, so to speak.
Essentially, a 90-year-old patient that has a history of some heart disease that really wouldn't tolerate anesthesia.
Rare entity called small cell lung cancer this evening. It is the second most common.
I'm Dan Sturman from Pulmonary Medicine. And I'm going to give you a little bit of a perspective with systemic therapies, with surgery, with radiation therapy. And I think this field is going to
talk about some of the drivers. So there's really a revolution in the lung cancer
from some of the other techniques, including radiation therapy, are the concept of enable intratumoral therapies, I hope, to be a key component of future cancer therapeutics. So this
cells have their proteins released, and then your immune system can gobble them up and then go try to.
And exposure to asbestos does things to the cells in which they
every day. Josh is the director of the High Reliability Organization.
This is chemotherapy, and this was recently FDA approved and likely.
The last question. In patients who are in immunotherapy, stage 4.
Hard or really to the other lung or anything like that. So this high dose of radiation can
have matched targeted therapies that are approved, and this list continues to grow.
Classically categorized as high risk. And increasing numbers of non-smokers are diagnosed with
already. If you just take out the tumor and then treat, you have less of these
technologies. The novel ablative therapies such as cryoablation. And
Dan?
I'll just mention in our lung cancer screening program, where we take high risk.
A lymph node in the middle part of the chest. Lymph nodes help fight infection, but we know that our study was quite astonishing that 1.3% of women with approvals of adagrasib as well as sotorasib, and we're also leading.
You remove a small triangle of lung around the tumor, and it's often used when the tumor is very.
We saw absolutely no adverse events, no bleeding, no pneumothorax, no pneumonia.
Analysis, trying to understand different subtypes. We have now started to
kind of compound that makes the radiation more potent, that really.
And using other materials is going to heal properly and the patient can recuperate.
Now, CD3 is expressed in immune cells, and by using an antibody.
Very tiny or very peripheral. It's also used if the patient's
For surgery, the standard treatment is chemotherapy and radiation, followed by immunotherapy.
And we work closely with our thoracic radiologists who aren't represented today, who are excellent here.
Presentation is more patients can safely have smaller lung-saving surgery.
By combining radiation as almost a vaccine where you kill the tumor cells, the little tumor cells, any further infections, it's the same idea. We're trying to make the radiation.
Dates on clinical trials at NYU focusing on lung cancer breakthroughs in this space.
Combination with chemotherapy and radiation therapy that are targeted therapies that have been developed, such
as there's a type of radiation that's very high dose. It's very precise. It's called
therapy are amazing. This particular person has been on cell percatinate.
Survival can be improved with targeted immune-based therapies, if you've heard from Dr. Sabari. And you've at our World Lung Cancer Conference both last year and this year, and show that significant improvements.
But sometimes more lung than necessary for these tiny tumors that we're picking up.
Create tumor antigens and initiate an immune response both locally in the tumor.
We hear that you can take all of these things from the uniport and put it into one
lung cancer. What I'm showing you here is that if we measure this biomarker, DL
therapy are. So the take-home message from at least this
to proximity to small cell lung cancer cells. And we see profound thoracic medical oncology group. But in Manhattan, we also have Dr. Elaine Shum, Dr. Rob.
Very much. We're going to talk about what's changed in surgery and why this is a candidate for these small operations like a segmentectomy. Well, like you see,
to be able to look at nodules, which may be so-called indeterminate nodules, and have a better idea.
Here at NYU, and was just FDA approved in August of 2020.
Move the tumor using a stapler or other instruments.
Drew DeMayo and Dr. Isaac Laniato, injecting using endobronchial ultrasound, this genetically
can get more lymph nodes, and you can also check many different areas.
After the conventional immunotherapy. I think in the early stage setting, both cancers can travel or spread to lymph nodes. So prior to treatment with tarlatamab there, with diffuse, what we call lymphangitic carcinomatosis.
Well, we're finding lung cancers earlier with CT screening. Many
growth on chemotherapy and immunotherapy or immunotherapy alone. We want to understand
your patients and your consideration, and I'm happy to answer any questions you might have.
Stop the radiation, and you can see a lung cancer plan where they came with the radiation, and they were for disease. Traditionally, it was just chemotherapy, and then we would use radiation only for palliation
Itself. So why would we do that? Why would we deliver therapies into the tumor itself?
In this space. Here's a patient of mine that I treated, and I'm pointing out on the left rate of mortality. But as we showed from Dr. Pass's data, is that and specifically here focusing on some of the updates in targeted therapy. So we looked at
patients, typically patients between the ages of 50 and 80, who are either active smokers equipped
between the blood vessels and the lung parenchyma. This is the lung here.
I would ask is, what is the biology of the tumor? So once somebody is progressing or having
AI being used in lung cancer treatment, I think, Dan, maybe you could...
dramatic response with regression in that lymph node. The patient also
using percutaneous or bronchoscopic approaches. And at NYU, we're very
them as a packet, and you can actually get more lymph nodes doing this. You can also
elucidate this because of the high number of lung cancers occurring in non-smokers, especially
that the segmentectomies did better than the lobectomies.
CAT scans and all the data that you have in these CAT scans to really determine the best way.
Talked about, this is a bispecific antibody. So it's an antibody that had clinical improvement in her symptoms. And most recently, 22 months out, her scan.
That lets surgeons remove less lung without lowering cure rates. But over a very difficult disease to treat. We haven't done as well with mesothelioma as we did.
Immune response in these patients that got the drug with radiation. So
and resistance is inevitable, right? That's what we're taught, but we can get
delivery to patients with stage 4 non-small cell lung cancer refractory to all forms of therapy.
With regard to tumors of the heart, I think that if it's involving the cancer, it's a separate entity, which is actually caused by asbestos.
That virus, your immune system sees the virus, and then you're protected with antibodies against.
A whole other question of how do we care for people who have had lung cancer who are
not. Harvey and Dan, I have two questions on mesothelioma.
And they are doing incredibly well. Everything's responding, but there's one
operation. So the goal is to shrink the tumor, treat invisible now. Well, in reality, robotic lung surgery uses the small incision.
That with what we've ultimately found by following these patients longitudinally.
The rate of detection was only 1.1%. So it's an interesting thought. Should we be
about whether they're likely to be malignant in the future? So I think that the availability of
activity. So we were participating in this phase 1 study of tarlatamab, now doing well. So when we think about lung cancer, particularly late stage lung cancer,
I'm going to go through a series of questions. Harvey, for you,
time of a standard of care bronchoscopy or potentially a needle biopsy to
we want to look at genomics or biomarkers, and we'll talk about doing sequencing in the tissue progression if there's progression in the blood or progression by CT.
One or a couple spots is try to eliminate the cells that have developed the resistance.
Or long-term responses. We're looking at a swimmer's plot here. Each patient is in tarlatamab. Again, the responses here were low, about 30%, but what we
level of these patients, and they did just as well. So that justifies the arms of the robot, and you can see everything as it happens in the operating room.
Cancer, we're going to focus on a rare mutation first called HER2, HE, more exciting, novel KRAS inhibitors in the non-small cell lung cancer.
And here with this radiosensitizer through Johnson & Johnson, that if somebody had a symptom that was bothering them from the cancer, like pain from cancer going to the...
Be very careful in dissecting the blood vessels. So you see the blood vessels here, because mesothelioma is associated with a gene also. And it's called
Dr. J.T. Poré and others, colleagues at Memorial Sloan Kettering, have worked diligently to try...
Toxic with advanced technologies. A way to potentially make the radiation more...
So far, that occurs in about 85% of patients. Small cell lung cancer is quite and continues to look very good. Moving off of HER2, which is...
Stage lung cancer, this means lung cancer that usually has spread to the lymph nodes in the middle.
To try to understand the biology of this cancer. And what she found in her
surgery in mesothelioma and combined with new immunotherapies.
Detector. But if you don't want to give any radiation to the normal tissue here, it's nice to
freeze a portion of the tumor. And the idea is to freeze a portion of the tumor to liberate.
So robotics helps surgeons to be more exact. Segmentectomy and
basically almost like robotic radiation. this was really a repurpose
cancer space. This is a pie chart of all the different driver mutations that have
in 3D. And you even can do it with one inside.
Still, despite lung cancer screening, majority of patients still present in advance. In July 2026, we're going to be hosting an international symposium exploring
Therapy was given. And you see again, the immunotherapy group is doing better.
extend the life of people with stage 4 disease. And in very select cases, sometimes
after 6 weeks of therapy, you see a dramatic response in the right chest, a dramatic.
You could tackle that one.
I have an answer as well.
All right.
Ben, why don't you start?
The 100% of the dose is all deposited basically in one spot, whereas the X-rays, seeing this okay?
Yep.
Yes.
Yeah, so this is a trial we're thinking about, opening here
Into the lymph nodes themselves, or by injecting into the tumor and having the lymphatics drain the therapeutic.
safe and everything in between. So this is just one of the many ways where we are trying to integrate.
January of 2024, and you could see her CT scan on that left-hand.
In stage 4 lung cancer, and that is changing, and we're trying to really push the envelope. And
So I think it's really important for patients to understand that we work as a team. We don't work individually. Pulse electrical field treatment. This is a novel delivery of electrical current through a
anesthesia so well, or a heavy smoker potentially that has.
It really does take a village to treat somebody with lung cancer. And I think, as you see here, it's
Better, they'll have better lung function long term, faster recovery, and more reserved lung.
essentially the so-called in situ vaccination. That recent advancements in robotic bronchoscopy.
Earlier with CT screening. Many tumors are small and on the outer edge of the lung.
On the y-axis on the left, 100% at the top, 0% at the bottom.
From 2014 to 2022. And as you can see, look at them very carefully.
okay. Dan, I think
Would have to be removed if you're going to have to remove a portion of the.
Dr. Sabari, Dr. Pass, and Dr. Joshua with this all the time, is we're trying to really.
okay. I'm sorry, we're not going to be able to get to all the questions, but Josh, I think one that gives
How has that changed? Well, this is the traditional standard, which is a lobectomy.
Yeah, it's a great question. So selpercatinib, formerly known as Loxo 292.
You take a stapler and divide the section between the.
Static setting, people with stage 4 lung cancer. By and large, some of the vaccines have been
2 years ago. So our first speaker is Dr. Harvey.
We saw that by doing the cryoimmunotherapy, we induced immune responses.
Uses small incisions and is the favorite of many surgeons, thoracic surgeons. It's easier with the robot, and you can get safe margins with the robot. You actually have one. And that gene, actually, if it's in your germline, if you're born with it, and locally, hopefully with negative margins, remove the tumor so that then.
Developed a concept at NYU called bronchoscopic cryoimmunotherapy. So this is the at NYU Langone, and I think there are characteristics, and I think that there are opportunities.
Thank you to everyone for joining us this evening, and really a task to talk about,
Cavities, usually within the pleural cavity or within the abdominal cavity. It's a
Probably there are some health problems that I get more concerned about radiating the lung, like
text lung function. Thank you very much.
Now it's my pleasure.
Outside of the lung itself, incorporate all this data, put it through a machine learning algorithm.
Of that lobe. Or you can do a non-anatomic operation long term. That's from Japan, but they only did segmentectomies.
sometimes even treat all sites of disease and hope for a cure. So basically,
to selpercatinib. But clinically, I would remain on therapy for as long as.
here at NYU is trying to use radiation in combination with those immunotherapies that
It's a combination of medical oncology, radiation.
A highly selective HER2 inhibitor. And what we're showing here is that this medicine.
I still think there's a tremendous role for lung cancer. For
therapy. Now, what can we do to try to advance this? One thing we can do is
responses. The same happens in this study, in which a different immunotherapy.
Raj Velmaswamy, myself, Dr. Salman Punakar, we have a presence out
In oncology, he's the director of the proton therapy at NYU.
The last 15 years. We're trying to take their CT scans and run them through an algorithm.
multiple different sites. And we saw that over time, basically, there was more of an
Orthopedic surgeons, that you can go ahead and actually remove a portion of the spine.
To the other lung and to the heart. So that is one way that we can potentially make radiation less
And you'd only have one incision to do all these operations. And you can see because it's been around a while and it's asymptomatic, but you also
term disease control. So one thing to help decrease the risk of recurrence post-op
who are exposed to a variety of cooking fumes and other
has been a revolutionary medicine in people with RET rearranged non-small cell lung cancer.
We need more people screened. We do screening at NYU. We got a chemoimmunotherapy to chemotherapy alone. The patients
radiation treatments to really bring cures to patients potentially without requiring.
What are the biomarkers in that cancer? And there are so many different options available. And what we try to think about is how can we block that signal with medication DNA? I think that's early on going to be helpful for us to think about next treatment. We heard a lot already from Dr. Pass about surgery being utilized in early stage.
And it lets surgeons remove less lung without lowering cure rates and move that segment so that that segment comes out and you can save the rest of the propensity to develop mesothelioma. But the mesothelioma is different. It's
cancer cells, and it also has an arm that blocks something called CD3.
Well, it's a great question. And I think that the answer is we don't know all the answers. I think we extreme concentration of the specific agent and thereby reduce the toxicity.
And prostate cancer in men and women. But lung cancer actually has the highest
cure patients without surgery. And we initially used this just for patients that really couldn't.
Panel with a cancer in the left upper lobe, the solid lesion. This was treated with
patient selection, and often we use surgery in this setting as well. So that's how we're
more potency than sotorasib and adagrasib. And in the first 10 patients,
from everybody, I mean, there's been a series of incredible talks here.
And lastly, this patient also had very nice response in the CNS.
It remains lung cancer, the number one cause of cancer death in the United States and worldwide. Approved antiviral therapy that induces both local and systemic anti-tumor immune response.
Another thing we can do for stage 1 disease.
So from a pulmonologist perspective,
the antibodies, you can get all of these taken care of if you remove
using robotic bronchoscopy to deliver a cryoprobe directly into the tumor.
In more simpler terms, there's cancer spreading through the lymph channels and in the size of the tumor. So we've seen multiple responses on trial, and this is one of the antibody drug conjugates that are being developed. These are smart chemotherapies that are for KRAS G12C, one of the more common KRAS alterations.
So, you know, I'm now getting old, and I remember when I first started
viral immunotherapy in 2026 in patients with advanced non-small cell lung cancer.
3 years now. So we're seeing durable long-term responses. This is
to the tumor microenvironment. You'll see that we conducted a first-in-human phase 1 dose escalation.
We then resect, so we have a window of opportunity to understand if the therapy is
stereotactic body radiation therapy. And this
I'll turn it back to you, Dr. Shashua.
Thank you, Josh. That was
exciting trial that we've treated some patients on, and it's something we're very excited.
He was the first division chief of thoracic surgery at NYU.
Change to a second or third line therapy. So we're working on ways to figure out the best way for patients.
And then I'll follow up.
Okay.
Yeah, so I actually have a slide on this.
We'll have to be careful in a certain subset of patients that have multiple malignancies and found that they can be as effective, these smaller operations, as a lobectomy.
Is both generally as well as tumor specific compared with multimodality therapy for these patients. And these novel agents combined with the
get more people to the screening centers. Now, what about surgery?
To squeeze as much as we can out of each medication. So referring to Ben and other radiation oncology
things you could be doing and spending it with us. So here today, I'm going to talk about some of the advances in radiation oncology.
So we have a large group at NYU. You've heard from Dr. Abe Shashua, who leads our
going on here. This is a robotic operation. We are removing the lymph nodes
that have been evaluable. Remember, each one of these lines on this bar chart are in the
stage 4 disease with both radiation and surgery to try to give the best chance of long
and the control group. The same thing happened in the Italian study, in which
cancer. And there's a complex mutation, but generally, when you have an abnormality, develop novel therapeutic options in this patient population. So the data I'm going to
robotic surgery improves precision and recovery. Chemoimmunotherapy, and Dr. Sabari, and we would think about what are the systemic types of therapy, wedge and segment, and there was no difference in the long-term survival. That the disease is such that it's difficult to find. And
lower the systemic concentration by reducing the amount of blood, vaccinating patients against their own tumor and against the antigens that are present in the patient.
Immunotherapy. So before going into some of the later stage setting, let's thoracic malignancies. So expertise in the lung cancer space.
So the traditional treatment paradigms for stage 1 and 2 disease and now.
And even cell therapy, which you may have heard about before, can be delivered directly.
That was incredible. Thank you. Thank you. So now, Dr. Sturman, you have to
therapy, especially this is treatment before the operation to make things.
A lesion in the left cerebellum. The cerebellum is responsible for gait and motor.
Now my oldest is, I believe it was 106 in my.
Of these antigens that will help you to treat, to be recognized and treated.
Emerge in the next decade is one that's going to be incredibly exciting. So you can inject a variety of
vaccines to elicit an immune response when someone's tumor is growing on or
the tumor, if you give the immunotherapy before and then after the
for cure and disease control. Another thing we've studied.
His office is next door to mine, so I talked to him.
Cancer. Those who received PEF had a dramatically improved overall survival, suggesting smoking women. So many answers to come, many questions, and we don't have them all.
Are there new surgical options if the tumor is near the heart or the spine? Adding dynamic group of speakers to talk to you about the breakthroughs in lung cancer.
From normal to a cancer cell, mesothelioma, grows and usually spreads within
particles that may predispose them to developing lung cancers. But I think that we have to
marker development and clinical trials and targeted therapy. And so he's going to tell us a little bit about.
There's been a dramatic drop in the number of deaths from lung cancer.
If we diagnose lung cancer early, the rates of cure is higher or are higher. So
basically the way we look at this is if somebody is potentially getting to
be a small cell lung cancer that was completely cured without chemotherapy ablation directly into the tumor, we can significantly increase CD8 T cell infiltration into
car building robot that they put the radiation machine on, so you could get lots of angle.
And then replace it with materials. And at the same time,
tell you what can be done now to improve outcomes significantly from where we were even a few.
These gold seeds, and that actually is able to block the radiation
and the non-immunotherapy group. It also will have certain studies that will with antibodies. Here you have a multitude of antigens. When you give
forward in the future, we're incredibly excited for where this field may go in the future. So thank you very much for your time, and I appreciate.
What we saw at 120 milligrams, we saw robust response 8520, which impressively has activity even after
things were like, and it's been night and day now with new drugs
who are refractory to frontline chemoimmunotherapy. Very exciting. So the question is,
so it blocks the radiation, so any of the normal lung around there doesn't get the radiation.
We saw was durable response. And my colleague, Dr. Salman Punakar here, led the trial. This is the second-line study for tarlatamab versus
lung cancer, which makes screening even more complicated, as you heard, related to the FAN study, where the injection was done, so-called abscopa responses. So PEF may, for a small subset of patients, replace surgical resection, but for other
history of smoking, and we see very common, genomic mutations in cancer. I want to point your attention to one specific group, and there was already a question.
This is the results of what happens with screening. Here you see the mortality
as groups, as our lung cancer group here, to study together going forward in the future.
So Ben is going to talk to us about newest advances in.
Most commonly non-small cell lung cancer, but we'll also touch on a more
newest thing that Dr. Sabari is also going to touch on is the use of neoadjuvant cancer. Many tumors are fully destroyed by surgery, upwards of 29 to 30%.
Right up front, we're able to then potentially guide specific therapy to the patient.
A vaccine, essentially. And those are really the main things I wanted to talk about.
From the pulmonary medicine and the interventional pulmonology approach to lung cancer, we still have a global health crisis that we're dealing with in lung cancer, despite all the advances that you heard from our colleagues.
Here you dissect out the artery, the vein, and the breathing tube. A wedge does not.
Those cells, and that way you could stay on the therapy that you're on, and you don't have to change. You've already had your radiation, so you already have that risk reduction of local control.
That Dr. Pass cited, which is in patients who previously smoked.
Is that Dr. Sabari has illuminated have altered the landscape for all stages of cancer. In theory, can achieve much higher local concentrations to increase the efficacy of
versus segmentectomies, the smaller operation. And you can actually see precise instrument as far as its control. And the outcomes are similar to other.
If you look on the right side of your screen here, you could see that the proton dose, you can see on
the results are promising, especially if you give it like.
This is so astonishing is because if you look at the NLST trial, the trial cancer, we've worked with a company here, Amgen, developing this medicine
and lymph nodes. You can inject a variety of immunotherapies, and I'll be talking about one form of immunotherapy may have a significant impact in combination with genetics and other factors. Heard from my colleagues, each of whom has mentioned that lung cancer screening is absolutely crucial.
Become let's just say immortalized and the cells change.
Bone bleeding from a lung tumor, or if the tumor's blocking and part of the lung, and
in which you remove a part of the lung called a lobe.
So we injected a modified cold virus that could be activated directly in. Even better.
Yeah. See, as everybody sees, it's really just directed right to the tumor. We do this at the time of operation, so when you wake up.
Less effective. Remember, a lot of our patients are having prior PD-1 or.
And then determine a probability that the individual will develop lung cancer, either into tumors and lymph nodes, and may eliminate some of the toxicities that are seen with systemic delivery.
In a trial that was looking at screening versus no screening.
And in a novel type of treatment, which is delivery of therapy directly into the lung cancer.
Minimally invasive approaches. The surgeon actually sits at a console.
And some of the advances that we're making together with our colleagues in the field. So these are my disclosures.
It's a high density core, which basically all that really does is find the cancer cells elsewhere, similar to whenever you get a vaccine in your arm, it usually has some of the youngest has been, 12 months. So it's the whole spectrum can get treated.
And these small resections save more lung. And it's not
as the medication was working, and as long as you're feeling well and there's no evidence of any clinical
new exciting targeted therapies. And the last is radiation therapy, which uses and other things don't get the radiation dose. We have a trial of
with lung cancer. The role of surgery is being questioned, but atrium or the ventricle, but certainly those operations in which they are involving.
You can also target metastatic disease directly in the lymph nodes by delivering the therapy directly.
Look at this pie chart, and we see that there are many different mutations that are seen in lung cancer or cancer diagnosed in the United States. Most commonly is breast cancer.
The tumor size, nodes, and biomarkers. And 2025 surgery.
Immunotherapy combinations that are being developed. There are also
the upper and the lower lobe. Located toward the outside, it's a great.
And when we've shown here that when we inject, when we deliver the cryo.
Are now proven safe for many small early lung cancers. Who's a good one? You can have combination operations with the either neurosurgeons or the United States, in which you compared lobectomy.
Charlie Swanton and his team, that air pollution and other particles in the
ventricle or the superior pulmonary vein have been in the past done
chemoimmunotherapy, and significant numbers of patients who had responses beyond.
And the patients were actually being randomized to either surgery or to radiation.
Artificial intelligence to query lung nodules and give us a better idea about their propensity.
Why does less lung removed matter? Well, randomized trials have shown
approaches. Here you see our colleagues in our interventional pulmonary operating room.
The event-free survival in the immunotherapy arm versus the non-immunotherapy.
and delivering electrical current to the tumors using something called pulse electrical field. So we have a significant immunological phenomenon induced by pulse electrical field that we hope.
And who had low dose CT scan. We also did concurrent blood tests in the lab and in the clinic, looking at overcoming resistance already.
One of the ways to attack lung cancer, as many of you know, there are multiple ways to attack lung cancer. The first
The idea of delivering a small probe directly into the tumor, ideally at the
Monitor patients, and we can understand if resistance is emerging. And in the lab,
them called Sybil, which was published out of the Massachusetts General Hospital several years ago.
Cutting out a small slice instead of a whole segment.
So this is my colleagues in our interventional pulmonology operating room to the tumor by taking an oral drug, valcyclovir or Valtrex, FDA approved by Dr. Shum. So how have we transformed lung cancer care? You've heard
help the immune system fight the cancer. So
the cone beam CT have markedly improved the feasibility, accuracy, and clinical integration of these novel.
Diagnosed with KRAS mutation non-small cell lung cancer. This is a study that targets DLL3 and CD3. We bring immune cells in.
Operatively is a collaboration with my surgeons where we put an implant
on a scan that looks otherwise normal. So the ability to give a probability for
being surgery. And this is the surgical robot, which you just saw.
Jane Shum asked this question in young female Asian women who are never smoking rate. And those patients would then go to the operating room with Dr. Pass and others and go work in this setting. We see here that BBO 8520 has
different approaches directly into the tumor. You can take chemotherapies that you otherwise would give. I heard from Dr. Pass that surgery remains our best chance for cure in early stage disease, often in
Cure and preserve more lung. Wedge resection is
compound. It's actually an immunotherapy, different from some of the targeted therapies we had.
What is mesothelioma?
mesothelioma is not lung cancer. Breathing reserve is not very good, so it's limited. Recent evidence has
coming down the pike. What I'm going to tell you about in the next few slides are areas of investigation.
A lot of hope and a lot of excitement remains with vaccines, and studies are ongoing.
Operations, they're not a biopsy, but really a segment is preferred.
So intratumoral therapies enhance cancer treatment through local and systemic immune activation.
Cells early, and then now this is the standard for many stage 2 and 3.
Specifically for the treatment of lung cancer. So you just heard Dr. Pass talk about
why is vaccines very exciting in that setting, because we get a piece of the tumor, right?
You could see they inject this white area into this tumor.
Rapid tissue diagnosis capabilities of artificial intelligence and advanced precision imaging will
either X-rays or other particles to try to damage the DNA of cancer cells and kill.
Been identified in lung cancer over 20 different mutations, 11 of them have.
So I think that this certainly may play a role in women in Asia.
We have a big crowd, I think, today, and we've assembled together a very exciting initiative at the Perlmutter Cancer Center. And his research focuses on
Short, we have not been able to target them well. Dr. Kwok Wong and Dr. The past 40 years, we are now starting to see light at the end of the tunnel.
We did a trial where we used a special drug that works on the immune system with
stage disease. And we also heard a lot about the technological advances of radiation therapy.
A number of the patients go home the next day after this operation.
This allows for more electrons to be in the vicinity of the tumor, which allows me
interested in a number of these approaches, including freezing tumors with what's called cryotherapy.
Tectomy, seen here, the lung is divided in multiple.
There are also conventional chemotherapy options that are available that are not wrong, but really
and very high response rates to the therapy and improves long-term survival chances.
I myself, Dr. Shishua, Dr. Shum, and others have patients who are on these treatments for
with water molecules and cause some damage. Whereas in these tumors that you inject this
adjuvant before surgery, as well as in the adjuvant setting after surgery, there's a lot.
And this enables us to take all of the pixels from a CT scan, not just from the lung, but
a mutation in a gene What it does is it tells the cells to continue to grow lane, and you can see the duration of time that people have remained on therapy.
Medical care medicine at NYU, and I've had the pleasure of working with Dan for many.
Them EGFR, which is one of the most common driver mutations. The reason occurring in about 30% of our patients with non-small cell lung cancer.
Before surgery boosts response rates to therapy and cure rates. Care is personalized up. It's almost like removing a whole branch when you only have to remove a.
Here at NYU Langone Health at this time.
AI is
bars are the response or regression in the tumor. So 71
the country. Certainly it's the favorite at NYU. The surgeon controls everything.
Also can inject viruses which replicate selectively in tumors called oncolytic virotherapy.
Maybe shrink or have a response so the surgery can be done.
Clinical trial of bronchoscopic cryoimmunotherapy in patients with advanced lung cancer.
Those with mesothelioma. Maybe you should do germline testing to make
having trouble breathing, then we would use radiation. But we didn't really use radiation outside of that historically. I have a 100-year-old patient on treatment for radiation right now. Really moving radiation from just trying to help a symptom to really going farther first, so you can not hurt the normal tissue as much. So this is a very exciting
therapies that we've had in the past. And when we ran this clinical trial, started in 2020,
and immunotherapy, which Dr. Sabari will talk about. And the whole idea is
to use CT scans and using artificial intelligence to be able to actually divine that even further.